네, 안녕하십니까. 저는 고신대학교복음병원 외과 김기현이라고 합니다. 지금부터 고신대학교 복음병원 비만대사수술 100회를 기념하는 제5회 고신비만대사수술 연구회 심포지엄을 시작하도록 하겠습니다. 먼저 개회사를 고신비만대사수술 연구회 회장을 맡고 계신 최영식 병원장님을 모시고 개회사를 듣도록 하겠습니다.
네, 여러분 반갑습니다. 고신대학교 복음병원 병원장이자 또 코스모스 고신비만대사 연구회 회장을 맡고 있는 최영식입니다. 저희 코스모스 연구회가 심포지엄이 벌써 이제 올해로 제 5회째를 맡고 있고, 그동안 수술 건수도 이제 100회를 기념하는 때가 되었습니다. 오늘 그동안 저희 이제 제1회 때부터 저희 심포지엄 자체가 아주 좀 독특하게 운영이 되었습니다. 국제 심포지엄을 시작해서 작년에는 라이브 데몬스트레이션을 이제 대만에 있는 황치근 교수님과 하였고요. 올해는 또 이런 코로나 사태를 맞이해서 또 이런 비대면으로 이런 이제 코스모스 심포지엄을 하게 돼서 매년 저희들이 준비하는 것이 이제 좀 다양한 방법으로 이제 적응해 나가는 것입니다. 특별히 저희 병원이 올해 이제 70주년을 기념하는 때가 됐습니다. 그래서 저희 이제 이 코스모스 심포지엄을 시작으로 저희 병원에 여러 가지 학술 행사들이 또 시작될 것입니다. 특별히 오늘 이 줌으로 참석하신 여러 회원 여러분들에게도 이제 참가해 주신 감사의 인사를 드리고, 특별히 우리 대한비만대사외과학회 안수민 회장님도 감사를 드립니다. 모처럼 이 이제 심포지엄을 통하여서 저희 비만대사 외과 수술이 더욱더 발전되고, 이 수술을 통하여서 이제 당뇨병 치료에도 획기적인 결과들이 나오기를 원합니다. 특별히 이번 심포지엄에는 미국 UCLA의 더슨 교수님께서 강의를 하게 됐습니다. 그래서 뜻깊은 행사가 될 것으로 믿고, 이 행사가 오늘 잘 마칠 수 있도록 이제 알고, 또 이 행사를 준비한 우리 서경은 교수님과 비만대사 코스모스 회원 여러분께 감사를 드립니다. 감사합니다.
네, 다음은 대한비만대사외과학회 회장을 맡고 계신 안수민 교수님의 식사를 듣도록 하겠습니다.
네, 안녕하십니까. 고신대학교 복음병원 비만대사수술 연구회 5회 심포지엄 개최를 진심으로 축하드립니다. 이런 뜻깊은 자리에 축사를 할 수 있게 시간을 또 비워주신 관계자 여러분들께 깊은 감사의 말씀을 드리고요. 전체 비만대사외과학회 회원을 대표해서 우리 최영식 연구회 회장님께도 깊은 감사의 말씀을 드립니다. 우리가 겪어온 것처럼 예기치 않은 코비드 팬데믹으로 인해서 이제 어려운 시기입니다. 훌륭한 심포지엄을 준비하고 훌륭한 강의를 공유하게 해주신 서경원 교수님, 그리고 관련과 모든 교수님, 그리고 헌신적인 팀원들께도 심심한 감사의 말씀을 전해드리겠습니다. 잘 아시는 것처럼 코스모스 심포지엄은 이제 비만 대사외과학회와 더불어서 이 분야의 이제 학문적 발전, 그리고 비만 대사수술 저변 확대에 아주 지대한 공헌을 해왔다고 자타가 공인할 수 있습니다. 이런 과정을 입증하는 증거가 바로 오늘 제5회 코스모스 심포지엄을 이제 고신대학교 복음병원 비만대사수술 드디어 100회 기념으로 진행하게 된 것이라고 생각합니다. 진심으로 축하드립니다. 우리나라에서 아주 소수의 센터만이 이룬 업적을 이룬 복음병원 센터 팀원, 그리고 모든 분들에게 존경과 치하의 말씀을 올립니다. 앞으로 코스모스 심포지움의 커다란 도약을 다시 한번 기원합니다. 또한 그간 부단한 노력의 결실을 토대로 해서 복음병원 비만대사수술센터의 무궁한 발전을 다시 한번 비만대사학회 전체 회원들과 함께 기원하겠습니다. 감사합니다.
예, 다음은 첫 번째 섹션으로 포스트 오퍼레이티브 매니지먼트 오브 메타볼릭 서저리에 관한 에리터 스의 강의를 듣도록 하겠습니다. 최영식 원장님께서 강의를 저장을 맡아주시겠습니다.
이거 해야 되겠다. Good afternoon, ladies and gentlemen. We started this first session. Professor Dobson, I apologize that I introduced you from Korean briefly. 그 저자분의 CV에 대해서 말씀을 드리겠습니다. 에릭 P. 더슨 선생님은 1990년도에 윌리엄 앤 메리 칼리지 버지니아에 있는 칼리지를 졸업하시고 그리고 이스턴 버지니아 메디컬 스쿨에서 닥터를 하고 프랑스에 있는 루이 파스테르 연구 대학에서 학위를 하셨습니다. 그리고 많은 논문과 많은 연구를 하셨고 현재는 미국 UCLA의 메타볼릭 서전의 칩 디렉터를 맡고 계십니다. 오늘 강의할 내용은 포스트 오퍼레이티브 매니지먼트 오브 메타볼릭 서저리에 대해서 강의를 해주셨습니다. 프로페서 도슨. We ask your wonderful lecture.
Hi, my name is Dr. Eric Dutson, and I'm the surgical director for UCLA's Center for Obesity and Metabolic Health, COMET for short. I'd like to thank you today for inviting us at UCLA to present our management strategies for patients in our obesity program who undergo weight loss surgery, specifically how to manage and prevent weight regain after metabolic or weight loss surgery. I'd particularly like to thank Dr. So, my colleague who spent some time with me at UCLA a couple of years ago. When we look at obesity surgery in general, the greatest weakness surrounding obesity surgery is actually weight regain. When we look at the various typically offered operations for weight loss surgery, duodenal switch is widely regarded as the most effective operation, but with a higher complication rate than some of the other procedures. Gastric bypass, at least in the United States and probably globally, is considered the gold standard weight loss operation. Sleeve gastrectomy has rapidly become the most popular global operation that we perform for weight loss. And the adjustable gastric band was quite popular in Europe and the United States a decade or two ago, but has become used much less often in comparison to the other more effective weight loss surgeries. Specifically, sleeve gastrectomy has really taken over as the most popular operation. In any of the operations shown here, the patient is at risk for either poor weight loss or weight regain. One of the major focuses on trying to decrease the risk of weight regain or poor weight loss is behavioral in nature. We spend a great deal of time in our program and other programs which are considered Center of Excellence status from the American Society of Metabolic and Bariatric Surgery. We have requirements ahead of the operation to do a significant amount of patient education in the hopes that that will improve behavior. Each of the operations that you see listed here is subject to poor weight loss and weight recidivism. Procedure by procedure, their risk level is not the same. For example, duodenal switch probably has the least rate of weight recidivism and probably has the highest excess weight loss. Gastric bypass in some studies is comparable to duodenal switch in terms of excess weight loss, but weight recidivism is slightly higher for gastric bypass. When we look at sleeve gastrectomy, it's been proposed in some studies out of Europe that the weight regain or weight recidivism is as high as 1 in 3 patients. That number has not been replicated in large studies, but when we do national database analyses, there is a clear difference between weight recidivism of gastric bypass versus sleeve gastrectomy, and that difference is magnified as the patient size or BMI increases. And when we discuss adjustable gastric band, which is performed rarely now in the United States and rarely also in Europe, this particular operation probably has the poorest weight loss of the 4 that are listed here and the highest rate of weight recidivism. At UCLA, we do not perform lap band surgery or adjustable gastric band due to a decision made to pursue the most effective forms of weight loss surgery if the patient has commitment to assume the risks associated with surgery. Thankfully, the risk of weight loss surgery is exceptionally low, and this is felt to be primarily due to the move towards Center of Excellence requirements in 2006 by the Center for Medicare and Medicaid Services, which is the US government's governmental healthcare policy for patients over 65 or patients who are younger than 65 who have economic or health circumstances that prevent them from buying private insurance. When this requirement was put into place in 2006, we saw an exponential reduction in complications associated with all forms of obesity surgery. And this difference was most clearly seen in gastric bypass, which is the gold standard. Since that time, unfortunately, our centralized governmental insurance agency has removed the requirement for Center of Excellence status in order for an institute to perform bariatric or obesity surgery. But nevertheless, our private insurance groups have all maintained the necessity for a national designation of Center of Excellence prior to actually paying for the surgeries for their patients. So to that end, UCLA, like most other programs in the United States, does carry a nationally designated Center of Excellence status, which is awarded through the American Society of Metabolic and Bariatric Surgery, or ASMBS for short. In our program, as I mentioned, we do not perform adjustable gastric band because of our decision that this is a poorly effective surgery with a high weight recurrence. We do perform Roux-en-Y gastric bypass, which again is considered a gold standard. We perform vertical sleeve gastrectomy, which was nationally recognized as an acceptable and non-experimental approach for bariatric surgery a little over a decade ago. And since that time has really taken over as the most popular operation performed, not just nationally here in the US, but globally. We also do a fair amount of revisional surgery, including a revision called long limb gastric bypass, which I'll talk more about as the talk goes on. Now, as you can see from the slide, the most commonly performed operation for us certainly is vertical sleeve gastrectomy, and this is reflected in the majority of bariatric programs throughout the United States. The revisional surgeries that we do are generally the result of patient complications because we are a tertiary and quaternary referral university center. We tend to be a location where complications from other programs will migrate for a higher level of expertise. The long limb gastric bypass operations that we've started to do on protocol have been not due to complications so much as poor weight loss. And currently, long limb gastric bypass is the only operation that we are doing simply for weight loss salvage, which I'll talk more about. When we look at our preoperative preparation for the operations that we do, for Roux-en-Y gastric bypass, we ask our patients to lose about 5% of their total body weight prior to operation. And this is for a variety of reasons. Primarily, we do it to shrink the liver. With as little as 5% weight loss, we can see a significant volume reduction in the liver, which aids in the technical ease of the surgeries, which are done all laparoscopic or by robot. We do not do any primary open operations at UCLA, and 5% weight loss does dramatically reduce the size of the liver because approximately 95 to 98% of our patients have fatty liver when they first are seen in consultation in the clinic. The additional benefit of the 5% weight loss is that it improves overall metabolic health in addition to the pure mechanical and volume reduction of the liver. We also know that insulin resistance is reduced with as little as 5% weight loss. Blood glucose levels improve with as little as 5% weight loss. And we additionally see the reduction of visceral fat, especially in the perigastric area, which aids in the technical performance of the procedures. The patients are admitted as a same-day case the morning of their surgery. They undergo surgery and spend either 1 or 2 nights stay in the hospital. And for primary Roux-en-Y gastric bypass procedures, we do not perform any postoperative imaging, but we do perform an intraoperative methylene blue leak test. The follow-up for our gastric bypass patients is part of a clinical pathway, meaning that all patients receive the same sort of baseline follow-up, which gets adjusted as necessary per patient. The adjustments that we have to do are rare, but in some cases we do. Those follow-up visits start at 2 weeks post-discharge from the hospital for the initial postoperative assessment, 3 months after their discharge from the hospital, 6 months after their discharge from the hospital, and 12 months. Once the patient reaches the 12-month postoperative period, we see them annually thereafter for our routine care. When we compare this to our vertical sleeve gastrectomy, because this is a clinical pathway and because our patients have such a short stay in the hospital, we do the identical post-operative and pre-operative preparation for both of these operations. So to repeat, once they go home from the hospital after sleeve gastrectomy, we also see them at 2 weeks, at 3 months, at 6 months, and then every 12 months. When we talk about revision surgery, the dynamic changes because the majority of the revision surgeries that we do are required because of complications related to patients' prior surgeries. Thankfully, most of these patients are not our own patients, but have been referred to us from other parts of the Southern California and southwestern United States region. We also require preoperative weight loss for these patients, but it is dependent upon their nutritional status. For example, oftentimes patients who have complications related to obesity surgery may slide into a state of malnutrition and may actually have a low body mass index. In these patients, obviously, we do not require weight loss, but what we will require for these patients is protein supplementation to try to return their albumin and prealbumin levels to normal prior to surgery in an attempt to reduce the likelihood of them developing any sort of postoperative complications related to their nutritional status. Now, in a straightforward revisional surgery, say, for example, a conversion of a sleeve gastrectomy to gastric bypass for excessive gastroesophageal reflux disease, that would be considered a uncomplicated and straightforward revision case. That patient also will stay 1 to 2 nights in the hospital only. The procedure we would expect to be done laparoscopically or robotically. In patients who do undergo revision surgery, whether it's from an adjustable gastric band to a sleeve, an adjustable gastric band to a gastric bypass, a sleeve gastrectomy to a bypass, or an anastomotic revision of a bypass, in all of those patients, we do perform in-hospital upper GI swallows to get a post-op day 1 picture of the anatomy related to the surgery that we've done. We do this for 2 reasons. One is to document that there's no leak at our anastomosis or our staple line, and the other is to get a snapshot of the patient's anatomy immediately after surgery in the event that things change down the road. Our follow-up schedule for revision patients, assuming that they don't have excessive needs, would be the same as the follow-up for our standard patients, which is 2 weeks post-discharge from the hospital, 3 months, 6 months, and 12 months, and annually thereafter for nutritional and weight loss monitoring. Now, at our initial post-operative visit, 2 weeks post-discharge, what we assess for the patients is their global status, including their incisions to rule out infections or hematomas. We assess what their level of activity is because we have patients up and walking in the hospital on the day of their surgery, and we expect them to continue to be mobile at home to reduce the risk of developing thromboembolism. We look at their dietary progress on their initial post-operative visit, and the way our dietary structure post-op is organized, the patients have approximately 14 days of liquid-only diet. The first 2 to 3 days of that is clear liquid, and then the remaining 11 or so days is any form of liquid. And we usually encourage patients at that time to take protein supplementations because their intake is quite minimal during this initial post-operative period, and protein supplementation is critical. We also look at their total daily calorie intake. Generally at this stage post-operatively, the patients are only getting 400 to 500 calories per day in some cases, and it's rare to see a patient who's able to get more than 1,000 kilocalories per day. We monitor their daily protein intake at this visit, whether it is by protein supplements, as in liquid shakes, or simply the food that they're taking in. And we'd like that to be around 80 grams per day. Patients are generally able to meet the 80 gram per day protein requirement better than they are able to meet their calorie intake of 1,200 calories. It's rare to see 1,200 calories on the first post-operative visit, but it's more common to see the 80 grams of protein being taken every day via supplements in the form of shakes. Most patients are able to do this. Additionally, at the first post-operative visit, we verify the patient's vitamin supplementation schedule as recommended by us and physical activity. Patients are not required to do aggressive physical activity of any kind. In fact, we encourage them to simply walk, and as long as they're able to walk for about 30 minutes uninterrupted per day, that's generally sufficient. The patient meets with the surgeon, the nurse practitioner, and the dietitian for combined assessment and recommendations. We don't concern ourselves with the patient's weight status at the initial post-operative visit. 2 weeks out from surgery, the patient will still have shifting fluid from their operation and the IV supplementation that was given to them, and we don't expect to have any significant adipose tissue loss at 2 weeks post-operative, despite the fact that we do see all the metabolic improvements by this time. Now, the next visit after the initial post-operative visit, assuming that the patient does not have any complications or issues that need to be followed up more closely, we see them at 3 months visit. In this visit, we also do a global status evaluation, and we include weight loss, because at the 3-month post-operative clinic visit, we would expect our patients to have a minimum of 35% excess weight loss. Now, it's important to understand this is excess weight loss and not total body weight loss. We calculate what their excess weight loss is based on an ideal body weight projection of a BMI of 25, which I think for Asian countries, 25 is still a bit of a high BMI, but in the United States, 25 is still considered to be the upper maximum of ideal body weight. At the 3-month visit, we will have had the patients get blood drawn before their visit, and we check their total protein levels, albumin, and all of their individual vitamin levels to make sure the patients are not experiencing deficiencies. Our biggest concerns are B vitamin deficiencies, calcium deficiencies, iron deficiencies, as well as fat-soluble vitamin deficiencies such as vitamin A and vitamin D. We look at the patient's dietary progress. At this point, 3 months out from surgery, barring any abnormalities, the patients should be able to tolerate any form of regular diet. If they are not, then radiographic imaging is indicated and potentially endoscopic evaluation. We look at their total calorie intake. The ideal is 12 to 1,500 kilocalories per day, depending on the patient's lean body mass. We look at their total protein intake as well via supplement and food. The majority of patients are able to meet their protein goal of 80 grams per day simply by eating and generally do not need to supplement. But in patients who are not getting a significant amount of protein in their regular food, we do encourage supplementation to meet a minimum of 80 grams per day. We verify that the patients are supplementing their vitamins and continuing their physical activity. Generally, most patients are able to exercise more vigorously than simply walking for 30 minutes, but for us, that's considered a baseline minimum. Patient meets with the surgeon or the nurse practitioner at this visit. They meet with the dietitian. A combined assessment is undertaken, and we make recommendations based on the patient's adherence to these goals and recommendations. Now, what about a patient who doesn't lose weight? So when we look at our assessment as part of our global status, we will check and see what their total weight loss is. And we're less concerned with the total weight loss than we are in the excess body weight loss. So if we see that our patient has less than 35% excess weight loss at 3 months, we know that this patient may do poorly in terms of overall weight loss, or they may be at high risk for weight regain. When the weight loss is below 35%, we reassess their food choices, we look at their activity, we increase the frequency of follow-up in these patients because several studies have shown that as the level of patient supervision increases, so does their weight loss. We begin asking the patients to do focused calorie counting as part of their own self-evaluation, and as early as 3 months, we will consider adding weight loss medications or referral to our medical nutrition team or both, because the growing body of evidence related to use of post-operative weight loss medications indicates that the earlier the intervention, the more effective they are. When we look at the patient's laboratory studies, we do focus on their protein levels to ensure that the patient is getting adequate oral protein either by supplement or by regular food. One of the things that we see when patients make poor food choices is that they obtain their calories from high sugar items such as shakes or other types of foods which are poor choices for weight loss at the neglect of protein. Additionally, we know that protein intake reduces appetite and causes a sensation of fullness, so we do focus on protein intake. At the 6-month visit, we do many similar assessments. We look at the patient's global status, including their weight loss. But at the 6-month visit, we would like to see the patients have a minimum of 50% of their excess weight loss achieved at 6 months. We look again at their nutritional status based upon their labs, total protein, albumin, and vitamin levels. We look at their dietary progress. At 6 months, the patient certainly should be able to eat any form of food that they like without having any issues. We look at their total daily calorie intake. Again, at the 6-month mark, we typically see patients between 12 and 1,500 kilocalories per day, which is ideal for weight loss. We look at their total protein intake. We question the patient about whether or not they're using supplementation to achieve the 80 gram per day mark. The majority of them do not need to do protein supplementation at the 6-month visit. And we also verify that they're continuing to take their vitamins and continuing the physical activity. Vitamin supplementation, especially in Roux-en-Y gastric bypass, is critical to avoid any sort of B vitamin deficiencies that may result in permanent neurologic damage. And at this visit, the patient also meets with the surgeon and the nurse practitioner and the dietitian, and we do a combined assessment and recommendations at that point. In patients who have insufficient weight loss at the 6-month mark, and this is assuming a patient who has had at least 35% excess weight loss at the 3-month mark, we again encourage patients to track their food, give written reports of what they're taking in as a daily food diary. We want them to document their exercise. And at this point, we are more likely to recommend medications, because the further out from the surgery the patient gets, the less effective we can expect a long-term outcome for adjunctive weight loss medications. We will refer these patients to our Risk for Obesity program, which is part of the COMET program here at UCLA. And the characteristics of the RFO, or Risk for Obesity program, is one of intense supervision. That is weekly clinic visits with weekly lab draws and weekly calorie counts, which in our program on the surgical side, we don't have sufficient resources to supervise that many patients that frequently, but the RFO program does. At the 12-month mark, and every subsequent 12 months afterwards, we look again at the patient's global status, their weight loss, and the goal for excess weight loss at 12 months for both sleeve gastrectomy and gastric bypass is 65% of excess weight loss. We again check their nutritional status, look at their dietary progress. Certainly the patient should be tolerating a regular diet at 12 months. The total daily calorie intake begins to uptick at the 12-month mark. We see patients still maintaining their weight loss, even if their calorie intake begins to rise to 1,500 or between 1,500 and 2,000 kilocalories per day, as the patient's body metabolism begins to adjust. We still ask them to get a minimum of 80 grams of protein per day. That's really a lifetime recommendation, and we verify their vitamin supplementation and physical activity. Patient at the 12-month mark will meet with either the surgeon or the nurse practitioner, sometimes both, and the dietitian for combined assessment and recommendations. Now, patients who are experiencing weight regain at 12 months or any time thereafter out from surgery, we will at times, depending on how far out they are, consider the addition of imaging. For example, patients who are 2 or 3 years out from gastric bypass certainly need to be ruled out for gastrogastric fistulas between the pouch and the excluded stomach to verify that that is not a cause of weight regain, because this does happen. And in the cases where it does happen, it effectively reverses the anatomic changes in gastric bypass. There are also endoscopic options for volume reduction of the gastric pouch, the gastrojejunal anastomosis, and in the case of sleeve gastrectomy, there is some budding data to indicate that a reduction in volume of a sleeve gastrectomy can provide up to 10% long-term weight loss improvement. And in patients who've had gastric bypass in the past, generally we see these patients 5 or 10 years out who've begun to regain weight, and they've failed all other more conservative measures for additional weight loss after gastric bypass. and who have a very compelling medical situation, such as severe diabetes mellitus, which is resulting in active end organ damage, such as kidney failure. In those patients, we will consider doing a so-called long limb revision, but we do that under protocol and recommend anybody else who does it as part of their algorithm to also do it on protocol. Presently, we've only done about 10 or 11 patients, and the results so far are mixed. We've had 4 or 5 patients who have not really had a tremendous improvement in their weight loss, whereas the remainder did have a significant addition to their weight loss, but we don't have long-term data yet. And my recommendation certainly would be for anybody employing this as part of their algorithm to study closely what the patient outcomes are. The long limb bypass effectively is a reconstruction where the jejunojejunostomy is advanced down the alimentary tract to approximately 250 centimeters proximal to the terminal ileum. And this is done to induce malabsorption, similar to what we see in a duodenal switch. And we need to therefore be very vigilant about monitoring patients for fat-soluble vitamin loss. Now, this is just a slide that summarizes what our current algorithm is at UCLA. And I would like to thank the organizers of this course very much for giving us the opportunity to share our experiences at UCLA and share our algorithms for patient treatment. And I would be happy to invite any questions at this time for our management strategies. Thank you very much.
소개 감사드립니다. 제5회 코스모스 심포지움에서 발표하게 되어서 영광입니다. 베리아틱 서저리 이후에 엔도스코피
Thank you very much, Dodson. Is there any other question about these lectures? Yeah, Professor Kim.
Thank you for your great lecture. I'm Ki-hyun Kim from Goshin University Hospital. So I have one question. I have heard that it is your conventional to ask 5% weight loss before the operation. Are patients mostly successful in losing that pre-operative 5% weight loss? Do you proceed with the operation even if the patient fails to lose the weight? You proceed operation. How many percent patient was successful 5% weight reduction?
Thank you for the question. I think the answer is that the majority of patients are able to lose 5%. And for us, in general, between the time of initial consultation and surgery tends to be about 3 to 4 months. So we will see the patient more than one time before surgery. And if we see that they are not progressing with this small amount of weight loss, then we will try various alterations to their preoperative diet to make it more aggressive. In fact, one thing that we will do, if they don't make the weight loss, we will put them on a liquid protein diet for at least 7 days prior to surgery. And a 7-day liquid protein diet will actually achieve most of the effects of 5% weight loss. We see a reduction in liver size. We see improvement of glucose tolerance. The real reason we encourage this so strongly is because we feel that it sets the patients on a pathway of keeping track of their diet, because so many of them pay no attention really and don't understand food selection and things like this. So I would say for our patients, the overwhelming majority are able to get between 2 and 5% of weight loss off before the operation.
Actually, in our center also ask to the patient strict, very low caloric diet. However, some patient doesn't follow our guideline. So yeah, we can find out its compliance.
One thing that's a little controversial is you could consider putting patients on phentermine or something before the operation. I don't like to do that because I think it takes the responsibility of food selection away from them if we give them medication beforehand. But in cases where the patient has an excessively high BMI, say more than 60, and they have lost no weight, in that patient, we would consider using medication just so they have some weight loss to reduce the hepatic volume.
Thank you.
Any other question? 네.
Hello, I'm Sang-Hyun Kim from Suncheon University Hospital. Thank you for your nice lecture, and I have two questions. The first question is when the patient fails to weight loss, approaching the excess weight loss, the goal of excess weight loss, do you use the weight loss drugs such as Saxenda or Qsimir?
Yes.
Yes, and if you use the drugs, when is the start line to use the Saxenda or Qsimir after surgery?
It's usually at 3 months post-operatively, and that has more to do with when we see them as part of our regularly scheduled visits than anything scientific. For example, we see them at 2 weeks post-discharge, and then we see them at 3 months post-discharge. At 2 weeks post-discharge, we can't really assess whether their weight loss is adequate. So we don't have another opportunity until 3 months. If at 3 months they haven't met the criteria of about 35% excess body weight loss, at that point we tend to be a bit aggressive in using medications like Saxenda and Qsimir. We are in the process of setting up a clinical trial to look at immediate use of weight loss medications before we know anything. So we plan to randomize patients into no weight loss medication or weight loss medication from the very beginning. And I think that patients who are on medications will show a significant improvement over those who are not. So.
Okay, thank you. Thank you
Sure.
so much.
My pleasure.
You have two questions. One, the other question, Professor Kim. Any other question? Yeah. Kim.
Thank you for wonderful lecture. Yeah, I'm Boo-Kyung Kim from Goshin University. I have one question. Thank you for your offering your teams, your center's nutrition program. You mentioned after 14 days, patient to stop the diet, and then 1,020 kilocalorie a day. How do you control this calorie? Your nutritional team always offer some example of food, or
Yes.
always control
Yes, that's a
contact.
good question.
Yeah, how often contact with the nutrition team and patient?
So that's a very good question. How do the patients know how many calories are in their
Yeah,
food?
yeah,
Most patients don't know.
yeah.
For the operation, in part of the preoperative preparation, we give them an entire volume of examples of commonly eaten foods, and based on weight, what the calorie content is of typical types of food. So we do ask patients to weigh their food or base it on the size of the food. Typically use the palm of the hand as a volume measurement for them, and we can give rough estimations of the calorie content based on the palm of the hand. Sometimes we use a plate example, but that's difficult because people have different sized plates. I know the hands are different size too, but it's a rough estimate. Post-operatively, they will meet with us about 2 weeks after they're discharged. They meet with the dietitian at that time, who will do a detailed food log with them if they have already transitioned into soft food. If they're still on liquids, we just ask what volume of liquid they take, because then we can calculate the protein and the total calorie intake. The access to the dietitians by email is much more common if the patient is having concerns or troubles. So they can access the dietitian by email as often as they like. And in patients who begin to show poor weight loss, we encourage our dietitians to reach out to them maybe weekly.
Okay, thank you for your answer. So you're in your team, always dietitian meet when patient when they discharge. So I think how do you control the cost of dietitian? Because in Korea there is no cost about the program of dietitian program and educational program.
Right. That's a very good question too. I think it's a problem, a universal problem. For us right now, we actually are able to bill not fully, but partially for access to dietitians. Now, the emails, for example, if we have a patient that needs weekly contact, we can't get reimbursed for that. There's no chance. But as part of a visit where I would bill as a clinician my fee for seeing the patient, the dietitian is included in that particular visit as well as a partial fee for the dietitian services. Now, in the United States, we have something called a global period, which means any type of operation that I do, for the next 3 months after the operation, we can't bill anything. So every visit is free. And after 3 months, then we begin regular billing again as an office consultation. During that 3-month period, since we can't get reimbursed anyway, and the first 3 months is the most critical for habit forming, I think, we encourage frequent contact, especially with the dietitians.
Thank you very much.
It's my pleasure.
네, thank you. Is there any other question about?
May I have just a quick
Professor Jim?
Yes, yes. I really appreciate your lecture. My name is Suminan from Yonsei University. I just have a simple question about the follow-up schedule. When it comes to the compliance of the follow-up and the patient aspect, what about the compliance with the follow-up schedule in your practice, and how do you think we can improve the patient compliance for the follow-up?
That's a great question, and I think it is the biggest weakness for bariatric surgery, because what we've noticed in the US when we look at the national data is that it's uncommon for people to have 5-year follow-up beyond about 20%. So we only see about 1/5 of our patients at 5 years because they don't come back. Either they've been successful with their weight loss and they don't want to come and see us when they feel well, or they haven't been successful and they're ashamed to come back. So I think for the first 2 to 3 years, our follow-up is fairly good. I would say 75 to 90% for the first 2 years, maybe. But by the time it gets out to 5 years, that drops way off to about, for our program, I think it's 20 to 25%. I think one of the really the best ways to try to improve that is to engage the patients somehow, to try and get them to play some role in their own follow-up and care. I think patients with higher education tend to have a much higher post-operative follow-up because I think they understand the need for nutritional monitoring and laboratory studies, et cetera. I think patients who have excellent follow-up with their primary care doctor, who is accustomed to treating post-operative bariatric patients, I don't know if it's any better if they see us or their primary care physician, as long as the primary care physician is familiar with bariatric surgery patients. So it's something that we do struggle with, to answer your question.
Thank you.
And my name is Dr. So. Hi, Dr. Dawson.
Hi, Dr. So.
Hi.
Good to
Thank
see
you for your wonderful lecture, and it helps us to improve our knowledge and enhance our program. I appreciate your time. Although we have did not met face-to-face meeting, but I thankful to meet you in webinar session, and I hope you are safe in COVID pandemic status. And in Korea, we are also in the same situation in the COVID pandemic. So in the near future, we hope to meet again.
It would be
okay, and our real life DM study will going on, and we will discuss about Zoom discussion in the February, late February. Okay, thank you.
All righty. It's very nice to see you.
Are there any questions about this topic? Professor Young Kim, 네.
Hello. Thank you for kind lecture. I'm Yoon Kim from Goshin University Hospital. I have a curiosity about the reason or cause of weight loss failure even after long limb revision, and one more about malnutrition or malabsorption doesn't occur in successful weight loss cases after long limb revision. Thank you.
Yes, so we have not done enough of the long limb operations to understand why the patients who have not lost weight don't lose weight. I think we've done about 10 operations, so I can't speak to how they managed to not lose weight. One of the problems that I think 5 of them have not had desirable results afterwards, meaning either they didn't lose weight or they developed steatorrhea, and very unpleasant steatorrhea because they're not absorbing fat. And for the patients who do not lose weight, my only guess is that they must be eating a tremendous number of calories to be able to compensate for that, because I simply don't understand how it's possible. That was the first question you asked. And then you had a second question. I'm sorry, I forgot it.
After long limb bypass, it doesn't occur of malnutrition or malabsorption in successful weight loss cases.
Right. You don't have to have malnutrition or malabsorption. You do have some component of malabsorption. It's the fat soluble vitamins that are most critical to watch out for. If the patients are compliant with supplementation and you monitor serum levels of vitamin A, vitamin D, vitamin E, that can be managed fairly easily. So not too much different from a standard gastric bypass. The problem you can run into is in patients who are very poorly compliant, because they can get very sick from malnutrition.
Okay, thank you. Compliance is the best for in procedure. Thank you.
Thank you.
네, thank you, Doctor. Now it's time to closing these sessions. Thank you very much your wonderful lecture, and thank you audience to fully discussion about these topics.
감사합니다.
네. Have a nice day.
Thank you.
Bye.
예, 감사합니다. 이것으로 세션 1을 마치고 브레이크 타임을 가지도록 하겠습니다. 2시까지 브레이크 타임을 가질 예정이고요. 저희가 그 문자와 메일로 보내드렸던 세션 2 다른 주소로 다시 입장을 해주셔야 됩니다. 그래서 2시까지 다른 주소로 입장을 해주시면 감사하겠습니다. 감사합니다. 지금부터 2시까지 브레이크 타임을 가지도록 하겠습니다.